afternoon, everyone. My name is Chris Russell, and I have the pleasure of presenting today's Public Health Ontario Rounds presentation on the update on Ontario's new tick-borne diseases of public health significance. Before I begin, I would like to do a land acknowledgement. Toronto is situated on treaty land. Public health respectfully acknowledges the traditional and ancestral territories of the First Nations, Inuit, and Métis peoples, whose lands we are hosted on today. We acknowledge that we are on lands of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat, and are thankful for enduring hospitality of the peoples across Turtle Island that allow us to live and work today. We stand with all Indigenous people, past and present, in promoting the wise stewardship of these lands time immemorial. Just a quick disclaimer that myself, and our speakers have no conflicts of interest. Before we begin, just a couple housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. Our speakers and moderator will make every effort to address any of the questions as possible. If any time during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. And now I'll pass over to our first speaker, Dr. Richard Mather. Dr. Richard Mather is a public health physician at Public Health Ontario, where he supports communal disease work, including vector-borne diseases. He will be followed by Dr. Antoine Corbeil, is a medical microbiologist at Public Health Ontario, where he is a portfolio lead for parasitology, enteric bacteriology, point-of-care testing, and education. Over to you, Richard.
Thanks, Curtis. The learning objectives for today's rounds are that by the end of this session, participants will be able to describe the epidemiology and clinical presentation of the 4 tick-borne diseases of public health significance in Ontario, identify the testing recommendations and testing process for each tick-borne disease, and interpret the lab investigations for each tick-borne disease and how they relate to a case investigation. There are 4 tick-borne diseases of public health significance in Ontario. Anaplasmosis, babesiosis, and Powassan virus were added on July 1st, 2023. And Lyme disease has been a reportable disease in Ontario since 1991. The black-legged tick, Ixodes scapularis, is the primary vector of all 4 tick-borne diseases of public health significance. And these ticks are primarily active in spring, summer, and fall, but ticks can be found any time of year when the temperature is above freezing and the ground isn't covered by snow. It is anticipated that the prevalence of tick-borne diseases will increase in Ontario in the future due to a number of factors, including climate change, animal migration, and land use changes that increase the potential contact between humans and ticks. I'd like to start with a case to help guide the discussion today before we get into the main part of the presentation. The case involves a previously well 68-year-old retired nurse living in Ottawa area who was bitten by a tick while gardening. 36 hours after gardening, the tick was found, and 1 week later, they developed a rash, fever, and myalgia. Rash was described as an expanding rash, 8 centimeters in diameter with a bullseye appearance, similar to the picture shown on the slide. Within 2 days of symptom onset, the patient visited their primary care provider. Routine blood work was normal. What would be the recommended clinical management for this individual? Would it be A, observation only, B, skin biopsy for Lyme PCR? Would it be serological testing for Lyme antibodies? Would it be oral antibiotics? Or would it be both serology and antibiotics? So to help guide clinical management, the patient's primary care provider reviews the Ontario Health Clinical Guidance Document on management of tick bites and investigation of early localized Lyme disease. So I have part of the algorithm shown here on the left part of the slide. And the boxes that are applicable to this case are circled in purple. And then on the right side of the slide, I've just highlighted those boxes to make them a little bit easier to see. So for this individual, they were symptomatic within 3 to 30 days following tick exposure. They had an expanding rash that was typical of an erythema migrans lesion. And they reside at an area that is a risk area for Lyme disease and had contact with ticks throughout their activities. So based on the information provided in this case, this is considered a clinical case of Lyme disease. We recommended to treat them for early localized Lyme disease, and Lyme disease serology is not indicated. And later on in the presentation, Antoine will talk a little bit more about when serology would be indicated and what the limitations would be. if it was used too early in the clinical course. So for this case, the healthcare provider in the Ottawa region knew that that region was a risk area for Lyme disease. But if they were not familiar with the risk areas, then they could consult the Ontario Black-Legged Tick Established Risk Area Map that's published annually from Public Health Ontario. So on this slide, I have two maps. The one on the left is from 2016, and the most recent one is the one that was published this year. On these maps of Ontario, health unit boundaries are in black, and the risk areas are shown in yellow or orange. The map was previously called the Ontario Lyme Disease Estimated Risk Area Map, and this year the name was changed to the Black-Legged Tick Established Risk Area Map to reflect the fact that there are now 3 new tick-borne diseases of public health significance that are transmitted by the same black-legged tick that transmits Lyme disease. There are various species of ticks that can be found in most parts of Ontario, clustered along the north shores of Lake Erie, Lake Ontario, and the St. Lawrence River, as you can see on this map. The current map from 2024 has 4 newly identified areas compared to last year, with 1 new area each in Chatham-Kent, Grey Bruce, Hamilton, and Windsor, Essex. The established risk area map is based on active surveillance, which is also known as a tick dragging, that involves going out into the environment to look for ticks. And a risk area is a location where at least 1 Ixodes scapularis tick is collected during both spring and fall sampling events. However, it's important to note that it's possible to find ticks anywhere in Ontario where they may have been transported by migratory birds. And ticks are not found uniformly in a risk area, but are found where the habitat is suitable, with ticks thriving in wooded, brushy areas with undergrowth and significant leaf litter keeps the ground damp. I also want to highlight 1 new addition to the Ontario Health algorithm this year for those of you who have used it previously. So you move down the symptomatic side of the algorithm, which is the orange side, there's a little star at the top that points to this box at the bottom that's circled in purple. And I've just enlarged the box to make it a little bit easier to read. And the box says to consider other less common tick-borne diseases such as anaplasmosis, babesiosis, or Powassan virus as either an infection or co-infection in individuals that you are investigating for a potential tick-borne disease. And there's also some links provided here for resources, including those from Public Health Ontario and the Infectious Diseases Society of America. Now I'm going to talk about the epidemiology of the tick-borne diseases of public health significance in Ontario. This table shows details of probable and confirmed cases of anaplasmosis and babesiosis that were reported in 2023 after these diseases became reportable on July 1st. As you can see from the table, for anaplasmosis, there were a total of 40 confirmed and probable cases reported last year. For babesiosis, there were 15 cases, and for Powassan virus, there were 0 confirmed or probable cases reported last year. And for context, for Lyme disease, for the entire year, there was just under 1,800 confirmed and probable cases. The age groups are shown here for which the cases were reported in, and the age group with the highest number of reported cases for both anaplasmosis and babesiosis was adults aged 60 to 79, which is similar to the peak age group seen for Lyme disease. However, in Lyme disease, there's also a smaller peak in children that is not seen here, but it is difficult to interpret trends based on small sample sizes. This graph describes seasonal trends in anaplasmosis and babesiosis. Y-axis has the number of cases, x-axis has the month. And although these diseases became reportable on July 1st, for some cases reported after this date, the onset of illness or a positive test date was earlier, and the earliest date is used, which is why you see some cases for May and June, even though they were not reportable until July. The green bars are for the number of cases of anaplasmosis, and blue bars is the number of cases of babesiosis. The peak month for cases for both diseases was in July, with anaplasmosis also having a smaller peak in the fall. Similar seasonal trends are seen for Lyme disease, with the majority of cases occurring in summer months and cases also occurring in spring and fall. And these trends correspond to activity of black-legged ticks, with larvae and nymphs most active in the summer and adults most active in the spring and fall. This map shows the number of confirmed and probable anaplasmosis cases by reported location of exposure in Ontario. And this map of Ontario is divided by public health unit boundaries, with a darker green color reflecting a higher number of reported cases of anaplasmosis. Highest number of cases were reported in the KFLA, Leeds, Grenville, Lanark, Ottawa, and Hastings, Prince Edward regions. And these health units also have some of the highest rates of Lyme disease in the province. And similarly, this map shows the number of confirmed and probable cases of babesiosis by reported location of exposure, with a darker blue color reflecting a higher number of cases. And similar to the anaplasmosis map, there were high numbers of cases seen in Eastern Ontario and Hastings, Prince Edward, and KFLA regions, but there were also some cases reported in some Central Ontario health units. But I just want to point out again that there were a very small number of cases, 15 confirmed and probable cases of babesiosis last year. So it makes it somewhat difficult to interpret trends. Now I'm going to be talking a little bit about the clinical presentation of the tick-borne diseases of public health significance. And while this presentation is primarily about the new tick-borne diseases of public health significance, I think it's helpful to start by reviewing some of the clinical characteristics of Lyme disease people may be more familiar with to allow for comparison to anaplasmosis, babesiosis, and Powassan virus infection. Lyme disease in Ontario is caused by the bacterium Borrelia burgdorferi, which is the primary cause of Lyme disease in North America. And there are other Borrelia species that can be found in Europe and may rarely be detected in certain US states. For a person to get Lyme disease, an affected tick must be attached for at least 24 to 36 hours for a transmission to occur. And after a person has been bitten by an infected tick, the incubation period, which is the time it takes for symptoms to develop, is usually 7 to 14 days. Lyme disease has three main clinical presentations. In early localized Lyme disease, which symptoms can occur 3 to 30 days after infection. Initial symptoms may be similar to other acute febrile illnesses, symptoms including fever, muscle and joint pain, or headache. Early localized Lyme disease is characterized by the erythema migrans rash that is an expanding rash greater than 5 centimeters in diameter that classically looks like a bullseye, but can have a variety of appearances and occurs in about 70 to 80% of cases. In early disseminated Lyme disease, which can occur weeks to months after infection, symptoms may include fatigue, general weakness, or multiple erythema migrans lesions, and also have involvement of the nervous system with symptoms such as a facial nerve palsy or cardiac involvement. In late disseminated disease, you can have swollen joints or neurological involvement. Anaplasmosis is caused by the intracellular bacterium Anaplasma phagocytophilum. Transmission occurs through the bite of an infected tick, with ticks needing to be attached to a person for 12 to 24 hours to transmit the bacteria. The incubation period after a bite from an infected tick is usually 1 to 2 weeks, with a range of 5 to 21 days. Clinical presentation of anaplasmosis is that infections typically present as a self-limiting acute febrile illness with symptoms including fever, fatigue, muscle aches, and headaches. Other symptoms may include nausea and vomiting or loss of appetite. Severe disease can occur in certain patients if diagnosis and treatment is delayed, including in older adults, as well as those with compromised immunity. Those with severe disease may have complications, including respiratory failure, organ failure, or death. And symptoms that aren't usually seen with anaplasmosis, which helps to distinguish it from some of the other tick-borne diseases, is that it rarely presents with respiratory symptoms, neurological symptoms, or a rash. For babesiosis, it is caused by an intracellular parasites from the genus Babesia, with the main species in North America being Babesia microti. Infected tick must be attached for 36 to 48 hours to transmit the parasite, with an incubation period of 1 to 4 weeks after a bite from an infected tick before symptoms occur. Transmission may also rarely occur through blood transfusion with a longer incubation period. For babesiosis, infections may be asymptomatic in up to half of those who are infected. When symptoms do occur, they may initially present as an acute febrile illness, symptoms including fever, chills, fatigue, headaches, muscle aches, or loss of appetite. Parasite attacks red blood cells and can lead to hemolytic anemia, which occurs when red blood cells are destroyed faster than they can be replaced. Some individuals can have a chronic infection with residual parasitemia lasting weeks to months. Babesiosis can become a serious, more prolonged or relapsing illness if treatment is delayed and can be life-threatening for certain people, including older adults and those with impaired immunity or impaired splenic function. Powassan virus, a disease that's caused by the Powassan virus that has two main lineages, with lineage 2 being transmitted by the black-legged tick. Transmission can occur after an infected tick has been attached for as little as 15 minutes, and the incubation period after tick bite is usually between 1 and 4 weeks. Powassan virus disease can initially present with a prodromal phase with symptoms such as fever, headache, nausea, or vomiting, maybe a transient period of symptom improvement for a deterioration of neurological function. With neuroinvasive disease, it can result in meningitis or encephalitis with symptoms including confusion, difficulty speaking, paralysis, seizures, or coma. Those with severe illness often have a more rapid onset of symptoms. And with severe disease, the case fatality rate is estimated at 5 to 10%, with up to 50% of those who recover having long-term symptoms such as headaches or memory problems. This table summarizes some of the clinical characteristics of the tick-borne diseases I've described and also highlights results of routine blood work if it is ordered in individuals with these diseases. For some of the criteria in the table, the percentage of patients who may have that particular finding is highlighted if this data is available. The time required for an infected tick to be attached to a person for transmission to occur. This time is somewhat similar for Lyme disease, anaplasmosis, and babesiosis, with a slightly longer attachment time required for babesiosis and a slightly shorter attachment time required for anaplasmosis. However, for Powassan virus, this is quite different, with transmission occurring after ticks being attached for as little as 15 minutes. Incubation period ranges from days to weeks, with a slightly shorter incubation period possible for Lyme disease and anaplasmosis. For skin lesions, Lyme disease has the characteristic erythema migrans rash seen in 70 to 80% of patients, but rashes are rarely seen with the other tick-borne diseases shown here. For other symptoms that may help to differentiate these diseases, Lyme disease can present with subacute or late manifestations. Both Lyme disease and anaplasmosis can have arthralgias, and anaplasmosis may also present with multi-organ failure. For babesiosis, you can have high fever and dark urine, with severe disease more likely if decreased immunity or low splenic function. Powassan virus may present with encephalitis or meningitis after a short prodromal phase. Individuals with severe disease can have sequelae in up to 50% of cases. If routine blood work is ordered, it's usually normal for Lyme disease and Powassan virus, although there may be thrombocytopenia with Powassan virus. For both anaplasmosis and babesiosis, you could see thrombocytopenia and high transaminases, while with anaplasmosis, you can have leukopenia, and babesiosis can have a hemolytic anemia. I'll now hand things over to Antoine to talk about testing.
Thank you, Richard. Hi, everybody. I'm Antoine. I'm one of the microbiologists working at Patel, Ontario. In the next slides, I'll go over some of the main testing methods for our 4 tick-borne diseases of public health significance and their limitations based on the timelines from onset of symptoms. So here's a graph showing the dynamics of Lyme disease over time. On the x-axis, we have the time since symptom onset, split over 3 scales, including over the first 12 weeks in black, then over months until the first year in blue, and then over years later in brown. The y-axis shows the level or intensity of the test response, and below you'll see the different potential clinical phases of Lyme disease, along with the performance of the main testing methods available. So PCR testing is shown in orange, blood smear microscopy in red, and antibody testing in green. So in the early localized phase of Lyme disease, the diagnosis is mainly clinical, especially if a typical erythema migrans rash is present. During that phase, the antibodies are not yet reliably positive, and doing a skin biopsy of the erythema migrans lesion is needlessly invasive. During the early disseminated Lyme disease phase, the serum antibody become more reliably positive, although early Lyme treatment may reduce the intensity of the antibody response. If neuroborreliosis is suspected and a lumbar puncture is already planned for other purposes, performing parallel serum and CSF antibody testing may be helpful, but is not required. The other testing modalities are not sensitive during that time. In the late Lyme disease phase, the best diagnostic option remains serum antibodies. If there's suspicion of late Lyme arthritis and serum antibodies are not conclusive at that time, then more invasive testing such as synovial fluid PCR may be helpful, but this is often not required. For anaplasmosis, the dynamics of infection are a little bit different. Anaplasmosis is usually limited to a febrile illness, which may or may not be prolonged over weeks in some cases. During the acute febrile phase, blood PCR for anaplasma is usually positive. In theory, You can also find the bacteria by doing blood smear microscopy during that time, but microscopy is not often reliable enough on its own to either rule in or rule out anaplasmosis. Serum antibodies are also not yet reliably positive, but rapidly increase over 2 to 4 weeks. After the acute phase, blood PCR performance decreases while serology performance increases. If an acute serum sample was collected, there is usually a fourfold or higher increase in titers between the acute phase and subacute or convalescent phase. That said, serology can remain positive for months to years afterwards, so a single positive serology result cannot usually distinguish between a recent or a more remote infection. The antibody response can also be affected by early treatment, and there's sometimes cross-reactivity between anaplasma and Ehrlichia antibody tests, limiting the interpretation. Next, we have babesiosis. Similar to anaplasma, Babesia infections can lead to febrile illness that may or may not be prolonged over weeks. Contrary to anaplasma, blood smear microscopy is more reliably positive for Babesia in the first 2 weeks of symptom onset. It may take a few hours or even days for the Babesia organisms in the blood to become visible by microscopy. Therefore, repeat microscopy may be needed, especially early on. Alternatively, PCR is also an option, but it's more costly and has a longer turnaround time over weeks. As with the other diseases, serology is usually negative during this acute phase. After the first 2 weeks of illness, blood smear microscopy becomes less reliable for Babesia. However, Babesia PCR can remain positive for weeks, even months, even if microscopy is negative. In principle, serology would also be positive during this phase, but its advantage over PCR is limited. Serology is also more challenging to interpret since patients may remain seropositive for years. A unique dynamic for babesiosis shown here is the potential for relapse. Since residual infection can persist for weeks to months, patients who developed an impaired immune system or an impaired splenic function, like hyposplenia or asplenia, can have a relapse of illness weeks to months following the primary infection. Relapsing symptoms are usually accompanied by a positive microscopy, similar to the primary febrile illness phase. Lastly, we have Powassan virus infection. As Richard mentioned, Powassan infection usually starts with a non-specific prodrome, followed by neuroinvasive disease, and then potentially some residual sequelae. During the prodromal phase of Powassan virus infection, PCR can in theory be positive in blood and CSF. However, there isn't a lot of data on test performance during that time, and the prodromal phase is usually too short for a PCR result to be actionable. And serology is usually negative during that time as well. Once the neurologic symptoms occur, the virus is usually no longer detectable by PCR in either blood or CSF, but the antibody response increases rapidly. The IgM antibodies usually peak around the 2nd to 4th week of illness, while the IgG antibodies usually peak between the 4th and 6th week of illness. Finding IgM antibodies in the CSF may confirm a Powassan infection, but CSF IgM testing is not routinely available in Canada at this time. Otherwise, a positive IgM result in serum is challenging to interpret on its own, since IgM antibodies can persist in serum for more than a year. Alternatively, a fourfold increase in antibody titers is confirmatory. And other flavivirus infections, such as dengue or West Nile virus, may cross-react with the initial test used for Powassan virus infection. Therefore, a positive Powassan virus antibody result is always automatically confirmed at PHO by using a specific test called plaque reduction neutralization test, or PRNT. So going back to our summary, we have here the 4 tick-borne diseases and their clinical presentations as described by Richard, along with the main recommended tests. So here for Lyme disease, in the early localized phase, clinical diagnosis is sufficient, while in the other stages, serology can be used. For anaplasmosis, during the acute illness, PCR is quite helpful, and then in the subacute to convalescent phase, then serology can be used. For babesia, in either acute, prolonged, or relapsing illness, microscopy is the first stage screening test, while PCR can be useful if smears are negative. And then for Powassan virus, in the prodromal phase, it's hard to tell whether PCR can be useful, and oftentimes we have to wait until neurologic symptoms appear, in which case serology can be useful. Another potential hint when assessing patients is the response to treatment, since both Lyme disease and anaplasmosis usually respond to doxycycline within 48 hours, whereas babesiosis requires a completely different treatment. On the other hand, management for Powassan virus infection is mainly supportive. So now let's walk through some recapitulating scenarios together. In the first scenario, if a patient presents with a potential exposure to black-legged ticks in an established risk area, but has no symptoms, then no testing is recommended. Lyme disease post-exposure prophylaxis can be recommended in some circumstances, such as those described in the Public Health Ontario algorithm on the right. But there are no established post-exposure prophylaxis recommendations for the other 3 tick-borne diseases. If a patient presents with a potential exposure to black-legged ticks in an established risk area and has evidence of a typical erythema migrans lesion, then a clinical diagnosis of early Lyme disease with appropriate management is usually sufficient. If a patient presents with a potential exposure to black-legged ticks in an established risk area with a non-specific febrile illness, then the following tests can be considered. Lyme serology can be considered if symptoms are atypical, prolonged, disseminated, or late. Repeat serology may be needed if the initial serology was tested early on and was negative. Anaplasma and babesia testing can be considered if symptoms are atypical for Lyme, severe, poorly responsive to Lyme treatment, or accompanied by abnormal blood work. In these cases, anaplasma PCR is preferred when within 2 weeks of symptom onset, whereas anaplasma serology is useful beyond the 2-week window. Babesia PCR can be considered if smears are repeatedly negative, although a PCR turnaround time is up to 21 days. Powassan serology can be considered as well if the presentation is suspicious for neuroinvasive disease. But as Richard mentioned, cases are fortunately still rare in Ontario. The following supplemental tests, including Lyme PCR, Lyme CSF testing, babesia serology, and Powassan PCR, are rarely useful and not usually needed to complete a diagnosis. Some of these tests also require PHO approval prior to specimen collection. So in all instances, we would recommend to refer to our website if you have any questions on these testing modalities and how to seek approval. The last point to note is that clinical information is always needed for testing to be conducted properly. So always provide the exposure history and travel details on the test requisition, along with the date of symptom onset, since test interpretation heavily depends on these timelines as we discussed. If Powassan testing is needed, the arbovirus intake form must also be specifically filled out with the appropriate clinical information for Powassan testing to be approved. Otherwise, testing may be delayed or canceled. And I'll pass it back to Richard for the conclusion.
Thanks, Antoine. So I'd now like to go over some take-home messages and implications for practice. Last year, the number of reported cases of Lyme disease in Ontario was much higher than the reported number of cases of anaplasmosis, babesiosis, or Powassan virus. And it is anticipated that the number of reported cases of the new tick-borne diseases will go up this year with a full year of reporting, compared to last year when they were reportable after July 1st. But there will likely still be much lower numbers of cases of the new tick-borne disease of public health significance compared to Lyme disease. The clinical signs and symptoms, along with blood work, can be helpful to guide the diagnosis, but testing may be needed to distinguish between anaplasmosis, babesiosis, Powassan virus, and Lyme disease. For individuals who are being investigated for Lyme disease, healthcare providers should consider anaplasmosis, babesiosis, and Powassan virus as either an alternate diagnosis or a co-infection. I've seen various estimates for the proportion of individuals who may be co-infected with 2 or more of these diseases. One example was a study on individuals with anaplasmosis and showed a co-infection with Borrelia in endemic regions may range between 2 and 12%. Final take-home message is that the optimal diagnostic test for each disease will depend on the timing of the test relative to symptom onset. Now I want to return to the case. The patient was diagnosed with early localized Lyme disease and started on a 14-day course of amoxicillin. They returned to the healthcare provider within 5 days of starting treatment with worsening febrile symptoms, including headache, stiff neck, fatigue, and confusion. The physician is concerned about possible co-infection with other tick-borne diseases of public health significance, and among other tests requested, which of the following tests may be considered: serology for Lyme antibodies, blood PCR for anaplasma, blood smears for babesia, serology for Powassan, or all of the above. So for this individual who is having worsening symptoms following appropriate treatment for Lyme disease, it is reasonable to, reconsider your initial diagnosis, as well as consider testing for the other tick-borne diseases of public health significance to look for either co-infection or a primary infection with one of those diseases. So thanks, Antoine, for clearly outlining the test results and helping inform those answers. So now I'd like to hand things back over to Curtis, who will be moderating the question and answer period.
Great. Thank you, Richard and Antoine. We will now move into the Q&A session. I will read them out to our panelists, and then we can go from there and answer them. Please continue to answer them as we go along, and we will try to get through most of them. So first question, I think I can actually answer, is, are anaplasmosis, babesiosis, and Powassan known to be transmitted by ticks other than the black-legged tick? So in Ontario, we consider the black-legged tick to be the primary vector for all 4 pathogens. However, for Powassan, as Richard noted, the groundhog tick and the squirrel tick have been known to have it. However, those 2 species of ticks don't readily bite humans. Good example is the groundhog tick, with its name, mainly lives in groundhog burrows. So that's where it is and doesn't readily come into contact with people. So for that one, we still really look at the black-legged tick as the main primary vector for all 4.
And Curtis, I just want to add on to that. So for those of you who are familiar with the eTick, its website, etick.ca, and they have data on ticks that people find either on themselves or in their yard. And you can take a picture, and then entomologists will be able to identify what type of tick that is. So if you look at tick data from 2023, if you look at all ticks that were found on a person in Ontario, if you filter it to Ixodes scapularis, there's approximately, I think, 1,500 ticks, Ixodes scapularis ticks found on a person. But if you look at those other ticks, the groundhog tick and the squirrel tick, I believe are about 50 of the groundhog tick, and I think 15 of the squirrel tick that were found on people. So much less likely to be found on a person than Ixodes scapularis.
Thanks, Richard. Richard, I think the next one's for you. The anaplasmosis and babesiosis cases, they were reported locally or they traveled? Most of the ones we had.
So those cases, it would include travel cases. For the maps, it was based on reported location of exposure. Rather than location of residence. So if an individual had some exposure in Ontario and some exposure outside of Ontario, then they would show up as a potential exposure location on those maps, because it is not possible to determine necessarily where they would have acquired the disease if they had exposures both inside and outside of Ontario.
Thank you. I had heard that these considerations given to lowering the length of time ticks are attached from 24 to 36 to 18 hours. Is that a pending recommendation?
I can go first, but welcome others to respond. I haven't heard anything about lowering it from 24 to 18 hours. Current recommendations from CDC, Public Health Agency of Canada, is that it's, for most people, it's attachment time of 24 to 36 hours or more. So in that Ontario Health algorithm, 24 hours is used as maybe a more cautious exposure threshold for determining a post-exposure prophylaxis would be indicated. But I think the evidence is continuing to evolve. So if there was evidence to suggest a shorter attachment time, then I think the guidelines would be willing to evolve with that, but I personally haven't seen anything.
Thank you. Currently, the Canadian Blood Bank does not screen for babesia. Do you see this changing in the future in light of these changes?
Thanks, Curtis. I can answer that one. Great question. In the United States, the FDA actually recommended screening for babesia in their blood supply since 2019 in 15 states, where there's testing by molecular tests that screen for babesia, acknowledging that for babesia, because of the persistemia that can persist for weeks, there may be risk in individuals that may be polysymptomatic or asymptomatic to transmit babesia. And there's been some cases of transfusion-transmitted babesiosis that have been identified through the United States blood transfusion cases. In Canada, the Canadian Blood Services has done a few risk assessments and has ongoing risk assessments to try to understand what is the risk of babesia in Canada in our blood supply. And so far, the risk was considered to be low. That being said, our understanding is that there are ongoing assessments that happen, and there's even targeted studies, if I understand correctly, that the Canadian Blood Services is targeting to be able to really understand the dynamic of increase in cases of babesia over time. But a lot of it is based on our epidemiological data as well, what we're seeing in clinical cases that will drive some of the decision whether or not to screen blood donors.
Thank you. To assist our clinical colleagues differentiate between these 4 tick-borne illnesses and when to order testing from PHO, is there a guideline that describes an approach to tick bites in acute care?
I can take that if you want.
Thanks, Samir.
Yeah, no problem. Great question again, as well as these pathogens are increasing in terms of the prevalence, although not as high as Lyme disease, obviously, because it's been established for many years. There is an ongoing discussion, both internally as well as the ministry partners, as well as the Ontario Health, similar to what Richard had shown in terms of the algorithm. Should we be expanding it to make it a tick-borne management of tick-borne diseases? So we are currently actively looking at it, but we don't currently have it right now. That's the answer.
Great, thank you, Samir. Shawn, I think this one's for you. Can PRNT for Powassan virus be done in a CL2 or need to be a CL3? So I think that's a lab level.
Yes, no, for sure. I can take that question. So here at Public Health Ontario, we do send to the National Microbiology Laboratory for the PRNT, or again, as Antoine had mentioned, the plaque reduction neutralization test. That is, again, the confirmatory test to check for neutralizing antibodies for Powassan virus. And Powassan virus itself is a risk group level 3 and would require CL3 containment levels to perform that plaque reduction neutralization test.
Great, thank you. Are all 4 infections more severe in elderly? What about in infants?
I can address that one. So in general, it's older adults that are considered to be at the highest risk of more severe disease, and infants aren't generally highlighted. However, any individuals with impaired immune system, and in the youngest individuals with a developing immune system, they would likely be more susceptible based on that, but they aren't routinely highlighted as a high-risk group.
There have been cases where the recommended treatment could be considered contraindicated, example, doxycycline in children, pregnant women, or people with tetracycline allergies. Should those cases be assessed before prescribing treatment? Richard, would you be able to start on that one?
Yeah. So in general, any individual should be assessed before prescribing treatment. There is some evolving evidence on the use of doxycycline in children, previously contraindicated due to the potential for teeth staining, but now can be used as a post-exposure prophylaxis in that age group. But certainly the physician should consider the indications for any medication and contraindications, as well as alternate therapies for all patients.
Sorry, start reading all the things. We always hear of clients who believe that they have Lyme disease and consistently get tested for it, but it comes back negative. Knowing that the symptoms are similar to babesia and the parasite is not routinely screened for by Canadian Blood Services, Do you know of a potential connection there?
Thanks, Richard. I can take that one. For babesia, as we mentioned, there is some overlap, especially early on in terms of the presentation, where someone can present with fevers without necessarily having the erythema migrans lesion, for example, where there is some overlap. For babesia specifically, there are some additional hints where on the clinical side, there may be more suspicion. One of them is having more severe symptoms, having really high fevers, for example, or visible dark urine to suggest hemoglobinuria, for example, along with some blood work, for example, the thrombocytopenia, the hemolytic anemia, where cases are found due to having these abnormal blood work results. If all of this is negative or isn't found in a patient, then the likelihood of having babesia is quite low. And that's where alternative diagnoses might be warranted in that case.
Great, thank you. I think I have another one for you, Antoine. It says, for babesiosis, Maltese cross blood smear are more diagnostics, which differs it from malaria. Do we do that test in Ontario?
Great question. So in terms of the diagnostic method by microscopy, there are some morphological details, or there are some findings that we look for on the microscope routinely for any patient that has suspicion for babesia. So if there's a request for babesia microscopy, then we go through our checklist, we go through all the different nuance and details that we can find on the blood smear to suggest babesia. So that is indeed part of the workup that we do internally while on the laboratory bench.
Great. Thank you. I'm getting a bunch of questions about ticks and tick testing, so maybe I'll chime in on some of these and try to answer them all at once. So with tick testing, all the ticks are tested at the National Microbiology Laboratory in Winnipeg by Health Agency of Canada. So they accept ticks off of humans. So currently they are not testing ticks off of animals. So there has been questions about using dogs for surveillance and stuff, and those are things that we're exploring with our animal partners. One thing with ticks off of dogs, while they're a good sentinel thing, is you can get hundreds, if not thousands and thousands of ticks, which can overload the system. So currently the ticks have to come off of humans, and we're looking at ticks, usually that through our actual going out in the field and looking for the ticks to see what pathogens are them actually out in the field. I'll maybe segue this into with Richard. One of the things with tick testing is it's more for us to look at where the pathogens are and where they're occurring, and then to let the health community know about that. However, for the individual person, sometimes too, you might find one tick and test it and it's negative, but you miss the smaller tick that was positive in another spot. So a lot of times for us from the tick world, it's more people are just being exposed to those ticks in that environment, and then what are the clinical pictures. But I'll pass that over to Richard.
Yeah, I completely agree with what you said about if you test a tick that is on a person, it may not be the only tick that they were bitten by. So if it's positive, then that can be helpful with a diagnosis. But if it's the tick that's taken off a person and tested as negative for anything, that could be a false negative, and it might reassure someone that, oh, I wasn't exposed to Lyme disease, but potentially they could have had one or more other tick bites that could have exposed them. So that's why tick testing is not recommended as part of the clinical management, because you could miss exposures.
Thank you. Climate change making areas more favorable for all types of ticks. Does Ontario or Canada have a plan to introduce screening for other diseases? Maybe I'll start. So we always are continuing to monitor what other pathogens are in the world and in the field. So a lot of the times we have connections with all our partners in the United States because they are bordering us and they seem to get things a lot before us. So we do continue to monitor to see what other pathogens they have, what their numbers are, and they would then try to look for those tick species in Ontario. That's the one great thing about e-tick is that we can then see what all the other tick species are, what we are getting, and what their numbers are. So just for an example, a lot of people worry about the Lone Star tick. We do see those numbers in Ontario every year, but we never see a spot where they've actually continually been in the same location year after year. So it doesn't look like they're establishing yet. And just for an example, like if you were talking about black-legged tick submissions, we might get 5,000 of those to e-tick every year. Well, if we're looking at Lone Star ticks, we might get 50 or 60. So we do keep an eye on the other ticks that are coming in, what pathogens they might have. So if other things change, same thing with the 3 new tick-borne diseases, there was evidence to show to look for those. We keep continuing to monitor. I can maybe take this one too. Any public health interventions to reduce tick populations since they're on the increase? we really look at the US again, because they have done a lot of studies in the US and trying to reduce black-legged tick populations. And a lot of the studies they've done where they can actually get the tick population lower, they actually, even though they can lower the tick population, it actually has no effect on lowering the actual prevalence of human disease, of say Lyme disease. So it's really hard to control the ticks, especially if you think of large forested areas, to really get into them. So that's why our big messaging is that personal protection, and then early identification, treatment, diagnosis. So big things again are personal protection. Or if you are going into brushy, wooded areas, make sure you're covered up, like colored clothing, so you can notice the ticks on you. Use proper repellents such as DEET or permethrin, because the ticks really don't like that. And the big thing is, when you do come out of that environment, is to do your tick checks. Check all the areas for the ticks and have your buddy check the areas you can't check. And then same thing too with those clothing that you have. Go home and put them in the dryer, because that, the high heat in the dryer will kill if there are any ticks on there. Why is there not a vaccine for people? I'm assuming this is for Lyme disease. I don't know who wants to start with that one.
I can take that. There was a vaccine that was approved about 15, 20 years ago. And then that was one of the reasons was pulled out of market, because there was not enough demand for it. Having said that, there are new rounds of research, intense research being ongoing to develop new vaccines for Lyme disease. It's still in the research phase, and there are some potential targets or that could be moved into clinical testing, but we have not seen any of those yet.
Great, thank you, Samir. If someone has a bullseye rash, saw the tick, had a blood test to see if positive, the test came back negative, symptoms are still present, what's the course of action?
I can start with this. So if a person has an exposure to tick in an established risk area, they have a bullseye rash, and that would be sufficient to diagnose them with a clinical case of Lyme disease and initiate treatment. In the Ontario Health algorithm, testing would not typically be recommended if they have a typical presentation of Lyme disease, because, as Antoine highlighted, the serology for Lyme disease can be negative early in the clinical course. So in this individual, it wouldn't be surprising that testing is negative. I think with the updated algorithm, the sensitivity is about 50% for early localized Lyme disease. So for this individual, I would say to initiate treatment. If they had worsening of symptoms after starting treatment, similar to the case, then you would consider alternate diagnosis. But if it's a typical bullseye rash, then that would be enough to say it's a clinical case of Lyme disease to start them on treatment.
Thank you. We're getting near the end, but we still have a couple times for a few more questions. So if anybody else wants to throw some more in the chat box. Great presentation. Sorry, I arrived late. So are the rates of babesia and Powassan in ticks in Ontario on the rise or constant? So if you're talking about it in ticks, the tricky part here is that the national lab now, they used to take all our ticks off of passive, so off of like stuff from humans and our active tick dragging. And now we're the only tick the ones off of our actual tick dragging surveillance. So we our numbers have changed a bit. We don't see a lot of even any of them. Really, the highest ones we would usually get is anaplasma, but they seem to don't really have big rises.
And for clinical cases, these diseases were just reportable last year, so a bit too early to see trends, but something we will be monitoring closely over the next few years to see how those numbers of cases evolve over time.
Okay. I think this is another joint one we have here is why does the guidance for treatment refer to risk areas if we know it's possible to find a black-legged tick anywhere in Ontario? It could prevent healthcare providers in non-risk areas from treating appropriately. The quick thing is the risk areas is where we actually know the ticks are actually established. So again, that's just part of your clinical picture that you know the ticks are in there versus areas where we don't have evidence of them, but we don't want you just to exclude it just based on that. And maybe I'll flow that over to you, Richard.
Sure. Yeah, it's a great question. And that is part of why we changed the name of the map this year. So it was the estimated risk areas map. It was changed to an established risk area map to try to clarify that point a little bit. So the map shows where we know ticks are. And the reason we know they're there is because we've done tick dragging and we've found ticks. But there may be other locations where ticks are found. We haven't wanted to include on the map areas where where tick dragging's been done and no ticks were found. Because that wouldn't guarantee there aren't any ticks in that area. It just means that day when we went out to look for ticks, no ticks were detected. So we don't have the negative regions on there because we want to help convey the message that ticks can be found everywhere. But the map is where we know for sure that ticks are there, and that's why they're being called established risk areas as a change in terminology from an estimated risk area, because it is potential that a tick could be anywhere.
Thank you. I think we have time for one last question. With no testing for early line and recommendation is to treat based on clinical presentation, is there a way to obtain data on cases that are not tested and thereby not reported to public health, i.e. HCP service or pharmacy dispensing doxy? The numbers would significantly be higher than what is in IFIS.
So I can address that first. So for that pharmacy dispensing of doxycycline, it wouldn't be for a case of Lyme disease. It would be following a tick exposure. So pharmacy dispensing is post-exposure prophylaxis, which is a person's being bitten by a tick. And to qualify that post-exposure prophylaxis, tick must have been attached for at least 24 hours. And the person is seen within 72 hours of tick removal. And in that situation, it wouldn't be considered a case of Lyme disease because it would just be a person who's been exposed to a tick. You're giving medication to prevent Lyme disease. If there is a person that has an erythema migrans rash, is seen by a healthcare provider, and that would be considered a clinical case of Lyme disease, then that should be reported into IFIS. As far as the number of people who are dispensed that post-exposure prophylaxis, I don't have that exact number. I'm not sure if anyone else has seen data on that on the pharmacy program.
Great, thank you. Sorry, we have a couple of ones in the thing, but I think we're running out of time. We'll try to grab one more here. One of the diseases had a tick attached of 12 to 24 hours for transmission. Is there a reason for guidance doesn't have attachment timing starting at 12 hours plus as opposed to 24? I think that really depends on which disease you're talking about.
Yeah, so the 12 to 24 hours was for anaplasmosis. So for the post-exposure prophylaxis, it's specifically for Lyme disease. There's no evidence to recommend post-exposure prophylaxis for any other tick-borne diseases of public health significance. That being said, it's possible that doxycycline that is able to prevent Lyme disease could potentially prevent anaplasmosis, because doxycycline can also be used to treat anaplasmosis, but there's no evidence for this at this point. So as that post-exposure prophylaxis is just for Lyme disease, and a tick needs to be attached for at least 24 hours to transmit the bacteria that causes Lyme disease. That's why that 24-hour threshold is used for post-exposure prophylaxis for Lyme disease.
Thank you, Richard. Sorry, that is our time today. So as we wrap up today's PHO rounds, I would like to thank Richard, Antoine, Shawn, and Samir for presenting and answering questions today. I would also like to thank everyone who joined us for today's webinar. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this as it will help us improve our programming. Lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you and have a wonderful day.